the idea of boundaries, it's an overarching concept. It includes multiple relationships, but boundaries have been much debated. Some folks say it's a useless concept, that it's too flexible, that it includes too much. Other folks argue that it's reasonable and useful. I tend to fall into the latter camp, not completely, but tend to. And I see it as an overarching concept regarding how we use and abuse our power in the context of an intimacy distance continuum in treatment. So how close we get and how far we are from our clients. Okay? And that it's reasonable to be fairly close under some circumstances, but about some things we can't be. So clearly it's against the law in California and most other states to engage in sexual intimacies with clients and to engage in a number of different kind of multiple relationships. But boundaries are a more global notion that says this is a professional standard for what is considered to be appropriate about contacts in a multiple relation or in a therapeutic relationship or an assessment relationship. This gets back to kind of the personal and effective aspect of treatment that, can we help but disclose information to clients about how we feel at times? And there are at least two dimensions to that. One of those dimensions has to do with affect that we might purposefully disclose. The other has to do with affect that we do not intentionally disclose. So the particular judgments here about disclosures and also about affect are these disclosures in my experience, is this being done for the patient or client? For me. Might it damage the client or the treatment? Although we're encouraged to avoid multiple relationships, which are a subset of the idea of a boundary violation, we're not required to avoid all of them. And this sometimes comes as news to folks, but not all multiple relationships are considered unethical or illegal. So some of you who are in community mental health, you were actually mentioning you were in a program where previous clients to the agency may be hired. That's not unusual. Many mental health programs are now, particularly county mental health programs, are now adopting the model of having what they're calling consumers become part of the service provision model. So it's not considered to be necessarily against the rules. Further, we've all had supervisors clinically who've also been academic professors for us, okay? Or many of us have anyway. Or we've had clients offer us small gifts. Right? Or we may give a client a card at the end of a successful therapy and the couple decides to have a commitment ceremony. So those are, quote, boundary issues, and they could even be considered multiple relationships, but they're not forbidden. And they're not forbidden because the basic issue here is that they're not reasonably expected to cause impairment or exploitation or to harm the client, okay, or the couple. So that's the general rule. Is it reasonable to expect that this could be harmful? A multiple relationship is generally being in one role with a client and then being in another role. Okay, so that's why we could say if I was a student of a particular professor taking a class and then getting supervised, that would be a multiple relationship. It's permissible, but it is a multiple relationship. It's more than one role at one time. Notice, though, that from a technical perspective, most types of multiple relationships cannot happen if the professional relationship has ended. It requires at the same time. The temporal aspect of this is that if I'm no longer in a professional role, arguably, I can't have a multiple relationship anymore because I'm no longer in a professional role. Exceptions to that include sexual activity with a client. We say to the client, oh, therapy's over, let's go have a party, let's go sleep together. That's considered a multiple relationship and it's also forbidden. But for the most part, the post-termination relationships are not so closely regulated. With avoidable multiple relationships, we want to ask three questions. We want to say, what's the likelihood of my objectivity and judgment being undermined if I enter into this multiple relationship? What's further the likelihood of my primary role as provider being compromised? And what's the likelihood of my being seen as exploiting this client? Let me just give you what's kind of a neutral example. The client loses his job. He's a landscaper. but he's had difficulty off and on being employed. You say, you know, you clearly still need services. How about you could do a number of hours a week of, you know, tending the gardens at my office in exchange for the therapy hour. Bartering is considered permissible as long as it's not contraindicated, okay? But depending on the clinical picture, that may be a terrible idea. Suppose this person does a really bad job, which is, by the way, why they got fired in the first place, of tending your gardens. They actually, as a landscaper, kill off half of your foliage. Are you likely to have some feelings about that? Okay. Not only that, but how do we differentiate the judgment we make about, I don't want you to do that anymore, or I can't work with you as a client, and then which role we're in when we're saying that? That it could contaminate the primary role as a provider, in addition to possibly compromising our objectivity. And it may, depending on what the arrangement is, be considered exploitative of the patient. Okay? If they've got to work 10 or 12 hours to see me for 1 hour, while they might have to do that when they're working at another job, I'm sure getting a lot of benefit for what they're getting, okay? Arguably. So if these risks are minimal, we're allowed to proceed. We should be sure to get consultation on each of the questions that I was just talking about and consider worst case scenarios. And we should also you know, be sure when we're consulting to follow my grandmother's rule. If I'm not willing to talk about this multiple relationship, don't do it. For the non-avoidable multiple relationships, I'm sure many of you have had incidental contacts with people in the community. You know, at restaurants, at movie theaters, at shows, a few months ago, excuse me? Thanks. At movie theaters and shows, and about a month ago I had a person tell me that they walked into the locker room at their local gym unclothed, and there's their client. Okay, so all kinds of possibilities. What does one do? Well, obviously we deal with the clinical ramifications. Secondly, we must use an informed consent model when we're talking to people about their contacts with us in the community. Let them know what to expect from us and talk about what's happened as well as what may happen, that we may see them out in the community. Consultation and a referral if need be.